Well, good afternoon, everybody. I think everyone has their food as of now. I'm Kerry Gross. I direct our cancer outcomes program here at Yale, and I'm very excited to introduce Dr. Stephen Katz. I thought it would be helpful to tell just a very short story about how this came to be. Roughly a year ago, we were asked to put together a strategic plan for our Copper Center, the Outcomes Center, thinking about how we would want to grow. What's our vision for growing this type of research at Yale? So as part of that planning process, I reached out to several colleagues and did an informal survey asking about what they're doing at their prominent centers, and also asked these colleagues, you could see various places across the country, what's the best, aside from Yale and your program, didn't want people to be biased, but what do you think is the best cancer outcomes program in the country? And interestingly, everybody pointed to Michigan.
Did you talk to my mother?
She actually pointed to Houston, but everybody else, no. It was actually really overwhelming as far as the widespread appreciation and respect for the whole cancer outcomes group, and particularly the leadership of Dr. Katz. So I went onto the website, and I've known about Steve and his work for a while, trying to figure out what's the secret sauce. How exactly do they do this? So can anybody see on this website what's a little bit unusual? Overall, it's a traditional academic website. The recipes. Who has recipes on their website? So if you drill down further, there are a variety of really good recipes on this website. But in all seriousness, this is not the secret sauce. I think this is emblematic of the fact that Dr. Katz is a really creative and innovative researcher. And I would put it this way. There are many people in this room and across the country who know how to answer research questions. We know how to apply methods to a question and develop with relative surety an answer. Dr. Katz knows how to ask questions, questions that will really help us to influence patient care and will help us to lead to transformative change within the healthcare system. So I'm really excited to, without further ado, welcome Dr. Katz.
Thank you so much. That is so sweet. I wish my mother was here. She's 92 years old. She lives in Florida. I taught her about Uber about 3 weeks ago, and she Uberizes 16 times a week. It's kind of cool. So I wish she was here, because that's so sweet of you. And also emblematic of your leadership and the kind of energy we had at dinner last night, great Spanish restaurant, and the kind of meetings I had this morning with senior and junior faculty. So I'm going to bring up my slides, and let's see, how do I do that? Tech person, bring up my slides, please, and I'll keep talking.
Former chief resident.
Yeah. So this is super exciting because what I'm going to do is drive population sciences into the exam room, which is part of the charge of cancer care delivery research, is to make the work that we do relevant and inform physicians about practice and hopefully make change. So the title of this talk is partnering with, no, that's not the talk, that's this afternoon. So the title of this talk is the impact of precision medicine on communication, encounters, what we learn from encounters with breast cancer. And that slide will be coming up pretty soon. So first of all, I want to acknowledge that the Copper group here, the Cancer Outcomes group here, is quite analogous to what we're doing at Michigan, blending great clinical sciences with decision sciences to do both population science work in the community, but also implementation and intervention work to improve decision making and the quality of care. Today I'm going to give you an example of the population side of the ledger and address what I think is one of the greatest advances in precision medicine today in the area of systemic therapy for breast cancer, and where we have the most to learn from in terms of where we're going next, that is germline testing in local regional treatment decisions for the same condition. So breast cancer is in fact a really interesting tracer condition for us to understand the success of where we are today and the challenges of where we're going tomorrow. So with that in mind,
this is it. This is the same
let's see.
CCPRV1.
Oh, this is so interesting. This has never happened to me before. Someone, no, No, that's, let's see.
You want to just email it to
Oh, this is really interesting. So where's my disk?
down here? Here we can reopen.
Open the disk.
Yes.
Okay, you do that. Open my disk. And hello there. There were supposed to be, there were two. Go, no, don't do that. That's already there. So no, drop that down.
Okay.
Open up that other file. Go to the disk. Go to that drive.
Okay.
Go to the drive
There you
and open it up. And
go. Computer.
okay. Go to is there doc? Go. I don't think you're on the drive. Are you on? No. Okay.
No, you got to go to computer.
No. Yeah. Go to the flash drive and go open that up.
There you go.
Yeah.
This guy?
Yeah.
Oh, it's different. All right.
And although it would have been fun to like just engage you without the data, we could have made that work. Are there surgeons in the audience? Raise your hand. Surgeons? And anybody who operates on patients with breast cancer, raise your hand. Medical oncology in breast? Medical oncology not in breast? Medical students? Medical students, raise your hand. Oh, good. We'll pimp some medical students today. So today, homage to team science. I already did that. Primer on treatment deliberation context. And I'm going to contrast the impact of tumor biology testing and germline genetic testing on treatment deliberation in breast cancer. But as we talked about neurology, this is the kind of work that I'm talking about here is exactly analogous to the kind of basic science in decisions that applies to any cancer condition for folks in this room. So again, we're the Cancer Surveillance Outcomes Research Team, Yale Copper Center. These are the kinds of groups that are bringing clinical sciences and decision sciences and the quality of care groups together under the auspices of cancer centers, which is a huge growth industry in the United States today. Between the National Cancer Institute, which is very receptive to this area of research, foundations, development, and other institutes like the Patient Picori Institute, there's tremendous opportunities for growth here. And it's great that under the leadership of Corey, this stuff is really taking off. It's super exciting. So 280,000 women will be diagnosed with breast cancer this year, and they will virtually all be well at time of diagnosis. Half of them will be diagnosed through mammogram, and the other half through a breast mass found by them or a partner or a clinician. And then they will be told they have a life-threatening condition, and then we'll make them very sick to make them better. That's the decision context that these women are faced with. Most of them will have favorable disease because of the influx of screening, the impact of screening. Can you all hear me back there? Okay, because of the impact of screening, we have a huge change in the staging. Many of you know that, such that 3/4 of women will have favorable prognosis at time of diagnosis. 60,000 will have ductal carcinoma in situ, and 2/3 will have ER positive, HER2 negative, tumor size less than 2 centimeters. The kind of and 100% of women with DCIS survive their disease after treatment, and well over 90% of those with favorable prognosis after diagnosis with invasive disease, well over 90% survive the disease after treatment. So the major role of precision medicine today is not what we're doing in metastatic disease. It's actually dialing down therapy to get the same quality of that outcome, the same kind of outcome with less burden and less morbidity in patients' lives. That is the major role of precision medicine today. And let's talk about how that's unfurling in breast. So the challenges in patients with favorable prognosis is that the net benefit of treatment options is often small and difficult to formulate for the individual patient. Management and treatment options are morbid and burdensome. Increasing recognition of potential harm if treatment is too aggressive. Primum non nocere, something that many of the clinicians in this room fully recognize and embrace. First, do no harm. Studies underway to evaluate strategies to reduce morbidity and burden on patients, and I would argue in no other condition more than breast has the evidence been driving to dial down the extensiveness of surgery, radiation, both whether you do or don't do, as well as doing less for when you do. And chemotherapy, to do or not to do. More evidence being driven in breast than any other cancer condition, and now evaluative tools that allow us to more precisely identify those patients. And let me give you some examples. The breast cancer treatment decision context. I'm a general internist, I want to say. I actually, even though this is a cancer center, don't care more about cancer than depression or cardiovascular disease. All God's children suffer. And any internist knows that there are many conditions that take people out in their lives and that reduces their quality. Breast cancer and cancer conditions are probably the best examples, best tracer conditions for this kind of decision study and decision interventions, and it's one of the major reasons that I've devoted my career to this area over the last 15 years. Incident episodic disease. Virtually all the treatments that confer lifetime benefits are initiated and is largely completed in the first year of diagnosis, basically saying that generally you get one shot, treatment is effective, and recurrences are not, the treatments for recurrences are not nearly as effective. Unlike testicular cancer, which can be treated at much later stages. Most patients are treated by the first clinician they see. This is surprising to both medical oncologists and surgeons. 95% of patients in the United States are treated by the first surgeon they see, and 95% of patients with breast cancer are treated by the first medical oncologist they see. Most treatment decisions are made during the first encounter. This is a very rapid process. Escalation, triggering of decisions that move very quickly, allowed a fair amount by the pressure and the pressingness that patients feel when the diagnosis is made. Patients receive multimodal therapy directed by different specialists. We talked about that this morning. Surgeons are charged with local regional therapy with or without radiation oncologists. Are there radiation oncologists in the room? Okay, I can say with or without radiation oncologists. And of course, medical oncology charged with navigating systemic therapy decisions. And treatment is widely dispersed in the community. My guess in Connecticut, 95% of medical oncologists take care of some breast, and they're among a population of 5 million in the state of Connecticut. How many cases? 6,000 cases a year is a guess. There'd be 300 or 400 surgeons who take care of them in Connecticut, widely dispersed. The timing of treatment decisions is a very important element of how the treatment decisions are made. At the time of diagnosis, it's rather chaotic. In our research, a third of women report that they hear about the diagnosis through the eyeball of a tech, a invasive radiology tech or invasive radiologist. They insist on finding that diagnosis, not waiting to get to the surgeon. Over half the patients know about their diagnosis before they go to their primary care doctor, which is a surgeon in breast cancer. Diagnosis confirmed by biopsy, information is collected. They see a surgeon who does history, physical exam, and uses imaging to estimate tumor size, clinical node status, and comorbidities. They undergo initial local regional therapy on the basis of that. And they frequently, on the basis of path node, margin status, and 21 gene assay, these are tumor biology and pathology tests, the initial surgery is revisited, and 10% of women who get a lumpectomy go on to have a mastectomy because of this information, or they go on to have additional lumpectomy to clear the margins. So women can look forward to more surgery after the initial decision. Just think about how that affects their decision-making process. After all that's collected, final local regional therapy decisions are made. As an example, a third of women after mastectomy have no disease such that they would be candidates for radiation, and that decision is made after the mastectomy. You can have a woman who says, I don't really want to have radiation. Mastectomy gives me a much larger, I will free myself of this by getting mastectomy over lumpectomy, and in fact, after mastectomy, the recommendation is to get radiation. So a pretty chaotic, complex kind of decision process in local regional. Systemic treatment decisions made at the end of all of this with regard to endocrine and adjuvant therapy. Tumor biology, extent of disease, and host factors, unfurling variably over time in the individual patient. Now, I've heard here there's more of a systematic approach to collecting that information, but I have major collaborations with a little place down in New York, kind of big, Midtown, kind of like that big, kind of like that big. 2,000 new breast cases a year, I won't tell you who they are. And they do not have uniform, standardized intake of their breast patients, even at Sloan Kettering. So I'm going to share data on how decisions are made from this landmark study that we are driving here at Michigan, that takes the power of population sciences and drives that right back into the clinical encounter. So this is the Individualized Cancer Care Study. It's a survey of 5,200 women newly diagnosed with breast cancer, population-based sample from cancer registries like Connecticut, like New Jersey, but in this case, Georgia and Los Angeles County, recently treated, let's see, I hope that's the, yes, recently treated, oversampling minorities. That survey is linked to a uniform clinical record, and we are linking all genomic and genetic tests for these patients from industry partners, which is a very novel kind of approach to building big data in the modern era of population sciences. We have surveyed all of their attending surgeons, medical oncologists, and radiation oncologists, and we're interested in mapping those clinicians' attitudes. And here at Copper, there's a major move towards understanding clinician networks, mapping those, and looking at the influence factors. Other groups are interested in that, including us. And so I'm going to share those data with you today. So the SEER program, as you're very familiar with, some of you, anybody work with the SEER program? Raise your hand. Okay, so some of you are aware that Connecticut has one of these, and these are programs funded through an NCI contract, unique state mandates to report incident cancer, nearly complete ascertainment, key goals of collecting information about first course of therapy, rich clinical and treatment data obtained through provider relationships, very important, growing data linkage initiatives with government and industry, and we've been able to capitalize on enriching that information beyond the medical record by going directly to industries who do these tests and linking that to our data, waiving patient-informed consent. It's a unique relationship one can build through state health departments who determine that the research is valuable enough from a public health standpoint to waive informed consent for the big data build because of the infeasibility of going to individual patients to get access to the data. Now, with that in mind, let's take a drive through decision making and begin with systemic therapy for patients with favorable prognosis. And remember, in invasive disease, that's 3/4 of patients with invasive disease. And so advances in precision medicine and systemic treatment. There has been major advances. The combination of ER, estrogen receptor, progesterone receptor, HER2, and 21 gene assay as a portfolio of tumor biology testing with limited pathology, delimited pathology information, the presence or absence of cancer in the first or second node that drains the breast, what we call sentinel nodes. That combination has markedly changed the rules of engagement and outcomes in patients with breast cancer today. That combination has largely usurped more uncertain histology and other extent of disease assessments through imaging, and I would argue has markedly improved the analytic validity, clinical validity, and clinical utility of evaluative testing for systemic disease candidates in breast cancer today. And with that, I would argue a reduction in overtreatment and a reduction in disparities of treatment in the U.S. Now let me make the argument. So currently, here's the recommendation from NCCN in this crowded slide about the use of the 21 of testing today. So systemic adjuvant treatment decisions, hormone receptor positive, HER2 negative patients. This represents 3/4 of patients with invasive breast cancer in the United States. If the nodes are positive, treat. If the sentinel nodes are negative, test. That's essentially what this is saying. If the nodes are positive, treat with adjuvant chemotherapy, endocrine therapy plus adjuvant. If the nodes are negative, endocrine therapy with or without adjuvant based on the results of the 21 gene assay as a low score, intermediate score, and high score. And the assay is the expression results of 21 genes that is placed on this metric. This is a report. How many of you have seen this report, 21 gene assay? Raise your hand. Many patients report that they see this. This is a report, this is the first page of it, that shows a recurrence score from that expression testing from 0 to 100. So patients see that they could be right here. Patient sees right, I'm here. And then they see the average risk of distant recurrence at 10 years after 5 years of tamoxifen. So this is basically showing you what your life will be like if you're on tamoxifen alone. It says that 12% at 10 years will have a recurrence of breast cancer. And it places that into intermediate risk. Now I have to tell you, many women do not perceive a 12% risk as intermediate. And the fact that that's placed like that is a company decision based on the company's analytic approach to what's going on here, accepted by medical oncologists. So recurrence score is generated, low, intermediate, and high risk. So the first thing that the patient sees is this sort of risk profile, okay? And I will tell you from our own research that patients' understanding of their risk is wildly different than what appears on this form. Now, here's the second page. The second page has this figure. And this figure right here reinforces BYOS. Bring your own statistician to the visit. Because I won't even go through this. But this is the most important figure. Tom, take a look at this. This is the absolute benefit of chemotherapy based on the recurrence score. And it's not an ordinal scale. It's not an interval. It's simply binary. If you have a high score, you can benefit from chemotherapy. And if your score is anything less than high, it's low. You cannot benefit from chemotherapy according to this figure. So they see a continuous risk, and that gets patients going. And then they see the second page, or a doctor turns to them and says, this is what the story is. High recurrence score, we recommend treatment. Low recurrence score, less than a high recurrence score, there's no benefit of treatment. That's currently what this report looks like even today. And the NCCN guidelines currently are low score, leave them alone. High score, treat. Intermediate score, it's a toss-up. That's the current approach that is being advocated by NCCN guidelines. With that in mind, let's see how the test is used and the impact on chemotherapy, and then we're going to move to surgery. Oncotype testing in this population that's representative of the state of Georgia and Los Angeles County, the two best cancer registries in the United States, 22 million people, and about 16,000 breast cancer cases a year. So this is a large piece of the pie in the United States. And so what you see here is that in node-negative patients, there's a small group of patients who have very small tumors who are node-negative. Remember, this is ER-positive, HER2-negative patients, and this is their node status. Positive, negative, and let's ignore the little tiny ones. You see in the sweet spot recommended by NCCN guidelines, a lot of testing is going on. However, in the node-positive group, and I would turn to our medical oncologist and say, is this surprising that in our population studies, 40% of them are getting tested before they get the recommendation for treatment? NCCN recommends treatment. And this, when I presented this in other groups, they're surprised by how much testing is going on in node-positive patients, where the current recommendation is don't test, treat. So it's a really interesting way the medical oncologists are moving into this space, rather aggressively with testing, which I would argue is a good thing from the perspective of doctors trying to dialing down therapy. Now this is an important slide, clinician recommendation for chemotherapy. We asked these patients, ER-positive, HER2-negative, first phase of our study, what their doctor recommended. Against chemotherapy, for chemotherapy, left it up to the patient, and you see the initiation of chemotherapy. What's most important in this slide is how little wiggle room is left after testing. So only 14% of patients reported that their doctor left it up to them. Most are reporting a recommendation for or against chemotherapy. So the impact of testing on uncertainty is demonstrated in this slide. Test results by clinical group. Now remember, I told you that low testing don't treat, high score treat, low score treat, and here are intermediate values. And you can see the distribution in node-negative and node-positive patients. About half the patients have this low testing score, and a relatively small proportion of patients have high test score. And this reinforces the notion that the test is largely being used to identify patients who can forego chemotherapy, because the majority of them who are tested are in that low score NCCN recommendation, leave them alone. So what are they doing? Recurrence score and clinician recommendation. So again, ER-positive, HER2-negative patients, node-negative in this case, so a little smaller sample, but it's our node-negative patients. And so here is strongly recommended, this is patient report, strongly against chemotherapy, from 2 to -2. So anything below 0 is against, and anything above 0 on average is for. And so what you see is that medical oncologists, and you see the no treatment group. So look at the ends here. A substantial proportion of these patients with ER-positive, node-negative disease, ER-positive, HER2-negative, node-negative disease, did not get testing. And you can see that it's kind of equivocal in terms of what the recommendation is. But for those who did get tested, a high score, you can see strong recommendation for, low scores, recommendation against on average, and you can see in the intermediates where we're not quite sure what we're doing, and there's some trials out there, Taylor RX and one other, to sort of parse out where the sweet spot cut point should be, is still in play. And you can see how medical oncologists how patients are reporting medical oncologists recommendations there. Now, in terms of the receipt of chemotherapy, it's very associated with the recommendations, as you saw in previous slides. So again, after ER-positive, HER2-negative, node-negative, breaking the ties on score, you can see low score, very low rates of chemotherapy use. High score, very high, and you can see intermediate values, we're still figuring it out. And no test, you can see about 15% of those who aren't tested go on to have chemotherapy. In terms of chemotherapy by node status and race, this is a very important slide. We've made there's been a lot of news in the last 20 years about disparities in the delivery of treatments for breast cancer, especially chemotherapy and the completion of endocrine therapy. And this slide shows, in fact, there are no disparities in the delivery of chemotherapy in populations as diverse as Los Angeles County and the state of Georgia. Large African American and Latina populations, we oversampled for that, and you can see here that in terms of chemotherapy, ER-positive, HER2-negative, adjusted for age, grade, and tumor size, positive nodes, negative nodes. So a really nice example of advanced and precision medicine zeroing out differences after controlling for clinical factors across race, ethnicity. Now, one last slide before I go on to surgery. Percent satisfied with communication about oncotype testing and treatment decisions. Again, good story here. Patients reporting a large percentage of those who were satisfied with the test decision and satisfied with the treatment decision around systemic therapy. So a very tight story about the advance of tumor biology and delimited pathology to drive recommendations for most patients that yields high satisfaction among those patients, and what medical oncologists would argue is pretty good decisions regarding tailoring therapy to individuals, and especially in terms of reducing any unwanted variability in treatment, for instance, race, ethnicity, as an example. Now, with that in mind, let's talk about local regional treatment decisions in exactly the same patients. Surgery and the role of germline testing today. So the first thing I want to say about surgery is it's much more complicated than systemic therapy. Okay? Here you have the algorithm for what kind of surgery to get, which is based on extent of disease, which is through a physical exam, imaging of the breast, margin status after lumpectomy. Now, what do I mean by that? You know, something like today, about 55% of women, maybe 60%, undergo lumpectomy, initially lumpectomy, with or without radiation. And if their margins, the margin, which is the distance from cancer to the margin of the pathologic, the surgical pathology specimen, is too small, surgeons get a little uncomfortable with that and they will do another lumpectomy or possibly move on to a mastectomy. So here's an example where this extent of disease influences initial appraisal, but also additional surgery. So think about that relative to systemic therapy decisions. Now, comorbidity was the only minor issue after extent of disease and surgery, and now the germline testing, and I'm going to talk about that. On the radiation side, it's extent of disease. Remember, I said extent of disease, tumor biology, host factors. Extent of disease is the surgery option. You are virtually assured of getting radiation if you get a lumpectomy. And you are about 30% probability of getting radiation after a mastectomy. So the extent of disease, the type of surgery you choose is very much going to influence whether you get radiation or not, and the rest of the factors are not particularly important compared to the extent of disease. So the other point that I've already made is that in our total sample first phase of patients who underwent, all of whom undergo surgical therapy, initial lumpectomy 66%, mastectomy 34% in this population, mastectomy after initial lumpectomy and 11%, re-excision alone, that's more lumpectomy, that's a waking up, going back to the OR in a couple days after surgical path has yielded some findings, and they're back in the OR to get another lumpectomy. So the gift that keeps giving in surgery, that's very different than in systemic therapy initiation, yes, no. Okay, so now with that as a background on surgical decision making, let's look at some results on how that decision is made. So here we have the surgical option in this population of 2,600 patients, our first phase of our 5,200, all of whom went through surgery. And you see that about 59% ultimately got lumpectomy, and the rest got mastectomy, of which half are contralateral prophylactic mastectomy. What does that mean? That means that instead of just having the affected breast removed, they had their unaffected breast removed as well. Bilateral mastectomy, which is surging in the United States and catching surgeons on their heels. Most surgeons today, when you hear them talk about this, are surprised about the narrative in the exam room today versus what it was 7 years ago. 7 years ago, 10 years ago, 6% of women underwent bilateral mastectomy after treatment of breast cancer, after diagnosis of breast cancer. Today it's probably over 20%. So a huge uptick in the use of that more aggressive treatment, again complicating the decision making for surgeons around this kind of issue compared to their medical oncology colleagues, which have a more algorithmic approach to systemic therapy, more algorithmic. So, and look at the wiggle room here, surgeon recommendation and initial surgery. So this is the patient report of what the surgeon recommended initially. And remember I said it was 14% for systemic therapy, and you can see 31% the surgeons are leaving it up to the patient. Surgeons have their opinions, initial recommendation, but patients report about a third. It's up to you. Lumpectomy didn't favor one or the other. And we've seen this before in terms of our research. And you can see the percent that getting mastectomy based on whether the recommendation was lumpectomy, left it up to the patient, or for mastectomy. This is not to say that surgeons are prescriptive here. This simply says that we all know surgeons rule. Surgeons rule the rules. They do. Any surgeons here? Raise your hand. Have you hugged a surgeon today? On your way out, find that surgeon and hug him. There's no more important person in your life when you need one than a surgeon. When you need a surgeon, there ain't nobody more important. And many of the patients feel that way. So the challenge is to precision communication. It's not just about precision medicine, it's about precision communication today. So with this backdrop a little bit about where we are with surgery, think about these statistics from this population of patients. 25% markedly overestimated distant recurrence risk after treatment. This is the population. How knowledgeable are they about these issues? 2 months after surgery, so this is a population of patients who we surveyed 2 months after surgical pathology was made available. 75% did not know that breast conserving surgery is equivalent to mastectomy with regard to survival. Now, that fact, that survival equivalence, has been known by surgeons for 25 years. You can't even put that on a surgeon questionnaire because surgeons just laugh you out of the room. And 75% of women who undergo the surgery don't know the answer to that question. 25% of patients at average risk for a second primary breast cancer who had both breasts removed reported that their surgeon said it would improve their survival. Now let me just tell you what that means. Average risk means they do not have a strong family history of cancer, breast cancer, ovarian, and they were either not tested or they tested negative for germline testing. Those patients have zero chance of the unaffected breast removal yielding higher survival. Zero. And surgeons know that. 25% of those patients are walking away thinking that their surgeon told them it would improve survival. Challenge of precision medicine numero dos, patient decision style. We spend a lot of time talking about getting those trade-offs right between different treatments, getting that information out in front of patients, trade-offs with regard to quantity and quality of life for this operation versus that operation, for systemic therapy versus endocrine therapy. But we don't spend a lot of time talking about patients' preferences for who's going to make the decision. When I came to getting treatment for breast cancer, I wanted my doctor to tell me what to do. We asked 5,200 patients this question. You're going to see it for 2,600. When it came to getting treatment for breast cancer, I wanted my doctor to tell me what to do. And Karen, I want to ask you, what proportion of patients said always? You've been in practice big time in New York, and now you're leading the way in quality and decision-making here. Yale, thank you for coming. And what do you think, what proportion said always? Yeah, you see, you're good on multiple choice questions too, because you know the way I asked it, medical students, I could have gone there and you go, now I know he must be anchoring high here because he's asking me. Always 31%, quite a bit 28%. So look at this, wanted doctors to tell me what to do. Always, quite a bit, sometimes not at all. You see those numbers here, the percentages who said that, and the proportion that got contralateral prophylactic mastectomy. That is both breasts removed. 12%, 19, 23, and 27. I wanted to make the decision. 27% got their breasts removed. The doctor makes the decision, 12%. So this is one of the biggest effect sizes you can see in health services research. And it's not based on the trade-offs. It's based on who's making the decision. Now, you can argue it's a good decision or bad decision, but this proves that physicians and surgeons are looking to dial down therapy. And in CPM, this is a growing issue in the United States, largely driven by patients' psychological reactions, patients' reactions to the treatment management moment. Every doctor knows that when you're in the room, you can't predict how anybody's going to feel tomorrow or in a year, but you know how they're feeling right there. And this is largely related to the reactions, students, that patients have in the exam room. And those reactions are very, very powerful, and you have to address them. Really important. Okay, so now with that in mind, I'm going to move on to germline testing. So we've just talked about systemic therapy and the role of evaluative testing. And now we talked about local regional decisions, that is surgery and radiation, prior to the advent of widespread germline testing in patients with breast cancer. Now you all know that genomic and genetic evaluation has essentially become free today. It's essentially zero costs. Gene editing, how many of you have been reading about gene editing? CRISPR-Cas9, please. If you haven't, how many know about gene editing, CRISPR-Cas9? You better. Oh my God, this is going to be sick in terms of what it's going to do. In mice, in insects 10 years ago, in mice now, and in humans tomorrow. And that's manipulating genetics and epigenetic phenomena in the cells. This is just measuring it. And measuring it has gotten very cheap, okay? So we've moved from, in breast, from BRCA testing 5 years ago to multi-gene panel testing. And let me talk about that a little bit by getting my slides back on. So there was a confluence of two factors. One is the advance of technology, which has been awesome. So I didn't really want to be a doctor. I wanted to be a marine biologist. But I got involved in healthcare after college and decided to go be a doctor. But I love bird biology. I'm a big birder. And what we're doing in bird biology today is killing what we're doing in human biology in terms of the genetic, genomic, phenotypic linking that is going on and understanding about bird behavior, bird phenotypic, and we're doing the same thing in medicine. So it's incredible. All of us need to be up to date on this, especially those of us who study the testing going on in the community, but certainly students are in a joyful state of education today because of what's happening. Myriad decision was the decision by the Supreme Court that you cannot patent a gene. You can patent a process, but you can't patent the gene. And within months of that decision, germline testing in breast cancer skyrocketed from about 6 to 7% to over 30% today. And we just happen to be starting to collect data right around the Myriad decision. So for all you researchers in the room, sometimes it just sort of lucks out a little bit, okay? In terms of getting these 5,200 patients, we sampled them every month beginning this month, that month basically. And so I just want to point out that what's going on in gene testing today was restricted to BRCA1/2, which still is by far the most important gene mutation for women to consider with regard to ovarian and breast cancer risk. We probably will not find another gene with this mutation prognostic information beyond BRCA1 and 2. And the reason for that is it's prevalent, although we don't know the prevalence in the cancer population, and it's a big cumulative risk. And what's more important for all of you, especially the students, is that the big risk for BRCA is breast cancer, but more importantly, it's ovarian cancer. The risk of ovarian cancer on the basis of BRCA1 is substantial cumulative risk, and there is no cure for ovarian cancer. So finding it early is or preventing it early is the only way you can survive it. So in fact, this genetic testing has become complicated because it's not just about breast cancer, it's about other cancers they have to consider. So there are other genes that are being evaluated with a much lower cumulative risk, but also much more prevalent in the community. So those test results are more likely to come back, small risk of a second primary breast and a little bit more common. This is the kind of panel testing that is going on in the United States that women have to face. So we've written about this, and the thing that's going on with germline testing is, think about this. The test results largely inform future cancer, not the cancer that you have, but the future cancer you face. Test results have implications for relatives. Unlike tumor biology and pathology testing, uniquely in evaluative testing in cancer, after a diagnosis, this test affects potentially the risks in your relatives. Explicit patient consent is required, unlike tumor biology or pathology testing. Patients must juggle two different schemas. Time of diagnosis, how do I get out of this room to get home? How do I get out of this room to get back to work? And now with germline testing, it's like, wait a moment, I have to juggle what do I need to do for the cancer I have, but also I have to think about future cancers? I mean, help me understand this. Wide variability in cancer risk estimates for the individual patient. Even those with BRCA, that individual patient, that risk estimate varies across patients by age and family history. Uncertain impact of results on preventive and treatment strategies. So let me show you some data. This is this is that first sample of about 2,600 patients, and we do a family history and test report analysis for these patients. And what you see here is that there's an average risk of patients. There's a high risk. This is the risk of a second primary, high risk, on the basis of, and this is sort of genetic test association guidelines, family history, aspects of the tumor. Triple negative means ER, PR negative, HER2 negative, and some ancestry. So kind of a complicated set of factors that drive the understanding of a woman at time of diagnosis, whether she's at average risk for a second cancer or at high risk for a second cancer. Okay? Now let's look at the results. Wanted genetic testing, quite a bit or very much. Remember, we surveyed women shortly after treatment. Okay? How interested were you in genetic testing? You can see that average risk patients, non-trivial interest, and in elevated risk, not 100%. This is really important. There are women at elevated risk that are not particularly interested in genetic testing. And there's a lot of women who are at average risk of a second primary, and they're quite interested. Receive genetic testing. Not all women at elevated risk receive testing. In fact, a substantial proportion didn't, about 45%. But quite a proportion of women receive testing at average risk. Timing of genetic testing. Think about the systemic therapy. What's the timing? Well, medical oncologists get that information, they bring it into the room, and there's a discussion about what we're going to do next. Here you have a germline testing, which is done, this is from patient report, before diagnosis, a small proportion, after diagnosis, but before surgery, and after surgery, when in fact the major outcome to consider with elevated risk of a second primary is removal of the breasts, contralateral prophylactic mastectomy. If you're at high risk for a second primary breast cancer, the main way to reduce that risk is to have your breasts removed. Whether you do or don't have a cancer right at this moment. Angelina Jolie did not have a cancer. She had her breasts removed because she was BRCA positive. Patients in the exam room with breast cancer have that exact same decision to make. Okay? But if the results come after surgery, that's not really good timing for that decision. Clinicians who order the test. Now we're asked patients who ordered the test. surgeons, medical oncologists, genetic counselors, others like primary care doctors. So now you have a test that's being ordered by different doctors at different times. And now here's the big kicker. Genetic counseling, who's talking to these patients about results? Who's talking to these patients who feel that they're at high risk for cancer? Strong interest in testing, many patients didn't talk to anybody. Strong interest, average risk, strong interest, higher risk. Many of these patients who had strong interest, higher risk of second primary, didn't get to a counselor. But look at testers. Tested average risk, tested higher risk. Among tested higher risk, many of them did not get to a counselor, okay? Which is the standard of care, NCCN guidelines, payers. Some payers are saying, you can't get genetic counseling unless they go, you can't get the test unless they go to counseling. And we're not going to pay you for it. Well, they better get ready for this, because most people getting tested aren't getting to a counselor. And they're not getting to a counselor on time. Surgeons, now let's do the last two slides and I'm closing. Surgeons' confidence. Surgeons are talking to these patients about this testing. Surgeons are pretty confident, you know, and they deserve to be so. They're smart, you know, they're chosen right. Students, how many of you are interested in going to surgery, being a surgeon? Raise your hand. Wait, how many students are there? Raise your hand. Come on. So you are young, you're like on faculty? Are you on faculty? Yeah. Are you resident? Pharmacy resident, okay. So anybody interested in surgery, going to surgery? It's a great subspecialty. I wish I would have been a surgeon. Maybe not, I don't know. I do work in the emergency room though, 1 day a week, and I haven't killed anybody yet, so everything's good. Surgeon confidence in genetic testing. You can see across their volume of experience, across their volume, moderate to low. Their self-report. So we've done surgeon surveys of these patients, and I'm giving you preliminary data, moderate to low confidence with genetic testing, reporting, and results. And here's kind of something pretty disturbing. Surgeon perspectives about the management of abnormal genetic test results. What's their recommendation based on abnormal results? BRCA testing. Not offering lumpectomy to BRCA carriers. That's not right. Women with BRCA carriers not only should be offered, but many of them take lumpectomy and go into higher risk screening. So here you have a group of surgeons, 65% not offering BRCA carriers, manage a variance of unknown significance, which is a mutation variant that has no prognostic value known. And they'll treat that the same as a BRCA mutation, 40%. Now, we don't know exactly what they do, but this is non-trivial. The last thing is patients' perspective about treatment decision-making based on what kind of information is given to them. Decisions dissatisfaction among patients who wanted genetic testing. Remember, a lot of this first phase sample wanted genetic testing. They talked about that. If they didn't talk to anybody, they weren't particularly satisfied with genetic test decision. If they didn't talk to anybody, they weren't particularly excited about their surgery decision. So here we have a situation where not talking to these women, whether they're at high risk or lower risk, carries a outcome of less satisfaction with both testing and with treatment decision making. So what did we learn? On the systemic side, there's some phenomenally positive news that we need to disseminate, which is that tumor biology tests have high clinical validity and utility. Remember, that's the decision about endocrine therapy and systemic adjuvant therapy, yes, no. Medical oncologists charged with ordering the tests and incorporating the treatment recommendations. Results powerfully influence recommendations. Patient involvement in test ordering, I didn't show you these data, and results management is modest. Only about a third of patients, about half the patients accurately recalled the results of their testing, suggesting that a lot of them leave it to their doctors to take that test results and put it into a recommendation. Patients report high satisfaction, major advance in precision medicine. I would argue the most major advance in precision medicine in the US today. Then take the other side of the same ledger for these patients. Germline testing is evolving rapidly. More complicated treatment decision. Major role of patients in testing. Any of you know, if patients start looking at an MRI report, you know, I mean, it's any of you, students, looking at an MRI report, you know it's gibberish for the most part, and you're looking at the bottom sentence. Higher variable ordering among different specialists, high variable test discussion, variable patient satisfaction, unknown implications with regard to treatment, and we are only at the beginning of understanding where germline testing in breast cancer fits with regard to, are we doing better or worse with regard to precision medicine today. So in the same patients, we see these challenges, both the good news and the more challenging news. And for us health services researchers, quality of care, communication scientists in this room, this is a very high priority for research going forward. Not only understanding what the trends will be, but implementing interventions to improve it. Thank you very much.